Yes, so here I am live for you to solve any doubt that you have in pathology mostly, but yes, we'll take the doubts also that you have any doubts of the clinical solving questions of anything that related to your preparation, maybe your Gurukul notes, or in general that you have a doubt in how to should you prepare at the outset also. So very good evening to all of you who have joined here. Very good evening to Goal to Aims. I hope that you actually achieved that. Priyansh Agarwal, very good evening, and Aditya. Yes, so any one of you is watching right now live, to let me know have you joined with me, and are you able to is my audio and video very clear or not? And as soon as you confirm it, we'll start the session. So the basic idea of doing this session is just to motivate you, ensure that any doubts that you have will be solved by us, and more importantly, because ultimately we all are together in this, and therefore the problems that we face are also same. Mostly what happens is during a preparation time there are some high and then some low. We will ensure that when you come in the lower part, we'll again put you in the higher part as soon as possible. So yes, others have also joined us. Very good evening, Prabhakar, Bhuvan, Nopala, Aditya, and yes, Mr. B. Shivastav, very good evening to you as well. I am fine. I hope that you are also doing fine and all. I have got a few doubts. I have taken this in my own email. But yes, if you have any other doubts that you want to, you can also add up in the live chat just now. The basic doubts that I have been asked, first of all, is by Mr. Yash. He asked, sir, please tell me how should I differentiate between primary biliary cirrhosis and primary sclerosing cholangitis? Also, please give me a basic idea as to how the T cell divisions are. GVHD and Carcinoid syndrome. So I have got, yes, a few doubts from Mr. Yash. I'll just see if my audio and video is clear or not. Cholangitis. Perfect. बिल्कुल सही है. Okay. So let's start with a first doubt. Okay, I'll first take the doubt that I'm being asked in the live chat, and I'll then move to the questions that have been asked on the emails. First of all, sir, what are the hot topics in pathology for AIMS exam? देखो dear Aditya, the questions usually of AIMS is very much clearly demarcating towards the conceptual understanding, and it cannot be said that which topics are important. But yes, if you talk about the chapters being important, so I really believe that the entire hematology is very important for AIMS exam. Talking about the general pathology, mostly the questions are asked on the immune system and the topic of apoptosis mostly, and topic on systemic pathology, they usually concentrate a lot on GIT, kidney, and about the lungs. That's my usual thinking, as I've seen a lot of questions being asked on these main exam questions. Thyroid has been a very favorite question for AIMS also, but overall I'll say, if you ask me, sir, what is the most important one, surely it is hematology. Sir, will there be concept videos of patho in Gurukul? I believe that every video that I make is mostly conceptual only, and the more conceptual you become, I think the more easier it becomes to understand pathology therefore. So without wasting any time, I'll talk about few other topics that have been asked to me. I'll put a dark background just to soothe your eyes here. So I'll talk about the first topic here, and that would be GVHD, okay, graft versus host disease. What is GVHD? As the name says, it is graft versus host disease. Remember, GVHD has few other names, like it is also called as RUNTS, Runts disease. It's also one more name, Runts disease. Actually, what exactly is GVHD? To understand this, we need to understand that what is the basic idea and why does GVHD occur? GVHD, as the name says, it is graft reacting against the host. So the first thing you should understand is, who is immunocompromised here? Who is immunosuppressed here? Is the graft immunosuppressed or the host immunosuppressed? A basic idea to understand this is, dekho beta, I usually talk in my classes as this: if I come to your home, if I go to your home, so obviously I am foreign to you. So you will try to reject me. But think of me. I am also coming to your home. So because I am foreign to you, you are also foreign to me. So I also try to reject you. So when you reject me, it is called as graft rejection. And when I reject you, it is called as graft versus host disease. So that what happens here is the immunocompetent donor T cells, they actually attack and destroy the immunosuppressed recipient tissues. Immunosuppressed recipient tissues. Now this is what is called as GVHD. Ensure you understand this point, that the graft is immunocompetent, whereas the host is immunosuppressed, and hence we talk about something called as GVHD, called as graft versus host disease. A few questions that have been asked here is, sir, which is the main organ which is involved in GVHD? Number one organ involved in GVHD is skin. Now this is the first organ of GVHD. Remember this first organ. It presents with rash and erythroderma. That is the first finding also. Apart from that, GVHD as T cell of the donor also destroys the immunosuppressed cells of the liver and GIT. So from the liver, the bile canaliculi are destroyed, and hence what they cause is jaundice. And because of the damage to the GIT, what is destroyed or damaged is actually the causing bloody diarrhea. So all these three are the features of GVHD, that is graft versus host disease. Okay, graft versus host disease. Apart from this, you should also understand that the first finding is the skin involvement. A question that has been asked recently is, GVHD depends on what? Does it depend on the organ size? It surely depends on organ size, because the bigger the organ is, it will have more amount of T cells. And secondly, if you put a immune cell into the recipient, will have more destruction. So the GVHD is mostly in the stem cell or the bone marrow transplantation, and less in the other tissues. But surely every tissue can have an effect of GVHD, which is called as graft versus host disease. Graft versus host disease. Achha. A second question that has been asked to me is that, sir, please talk about the carcinoid tumor. Now this is a very good topic, so I hope that you all are waiting for it. The name is carcinoid. So why has this been named as carcinoid and not carcinoma? Just socho. The name is not carcinoma, the name is carcinoma like, and hence the name is carcinoid, carcinoma like, isn't it? Ab dekho, this originates from the origin of this cell. What is the origin? The origin of this cell is actually what? It's a Kulchitsky cell, okay, which is also nothing but a neuroendocrine cell. So can you name some carcinoid in our body? The best way to classify this is to first understand it could occur in all the type of urinary system. It can occur in the foregut, it can occur in the midgut, and can also occur in the hindgut. Okay, can occur in the foregut, midgut, and hindgut. The three types of carcinoid that can happen. Now, when I talk about the foregut, midgut, and hindgut, one thing will help you to remember. Okay, what is foregut? Right from the alimentary canal up to ligament of Treats, right? And then comes the midgut, and then comes the hindgut. So if I talk about these three types of demarcation, the first thing you should understand is which of them is aggressive. So among this, the most aggressive is midgut. Okay, if we talk about the aggressive nature, so foregut is mildly aggressive, midgut is very highly aggressive, okay, and the hindgut is also mildly aggressive. Okay, it is not very aggressive. So the most aggressive here is what? It is a midgut carcinoid. That's one important thing. So if I talk about a lung carcinoid, it's mildly aggressive. But if I talk about the ileal or in the duodenum, it becomes highly aggressive carcinoid. The hindgut carcinoid, for example, that in rectum or in the sigmoid colon, that becomes again mild carcinoid. But in the lungs, it surely becomes a mild again carcinoid. So most aggressive carcinoid are those in the ileum and the duodenum, and hence they're regarded as malignant unless proven otherwise. Okay. Often a question is asked, sir, what is the most common site of carcinoid? Overall, the most common site of carcinoid is a tracheobronchial tree. So tracheobronchial tree includes every part of lung, right from the bronchus also. But if that is lung separately and supposedly it is ileum separately, so then after this comes the ileum. Okay, so if you have an option of tracheobronchial tree, then only you choose this. But if you have an option of lung separately, ileum separately, duodenum separately, and the appendix separately, then the most common is becoming ileum. Often I've seen, as soon as I ask this question to the students, they quickly answer appendix. So please remember, the most common tumor of appendix is carcinoid, but the most common location of carcinoid is not appendix. Okay, that's one more thing you should understand. Secondly, often a question is asked as to, sir, what is the type of carcinoids? See, carcinoids can be into typical carcinoid. Now, this typical carcinoid is nothing but a benign carcinoid. Okay, benign carcinoid. Therefore, the process becomes good. But it can also be a atypical carcinoid. Atypical carcinoid is nothing but a malignant carcinoid. So often I have seen a question being asked to me in my regular classes also. So please tell me that in carcinoid, what should I take as the nature of carcinoid in the PET scan? So see, if it is a typical carcinoid, it's a benign carcinoid, and therefore it will take obviously less uptake or no uptake in the PET scanning. But the moment you see a malignant carcinoid, it will have very, very high uptake in the PET scan. Okay, now how do you screen for carcinoid? What is carcinoid? Do you actually know what is a carcinoid? Carcinoid comes from neuroendocrine cells. They're those cells which releases neuroendocrine hormones. And which of them are neuroendocrine hormones? It is serotonin, it is VIP, it is ACTH, it is calcitonin, bombesin. These actually are the neuroendocrine hormones. So you can either measure these as a tumor marker, or you can measure the byproducts of these hormones. For example, 5-HIAA. Okay, this becomes a good marker of a carcinoid. Some other examples of carcinoid are like pheochromocytoma. They also are a neuroendocrine tumor. They also are a neuroendocrine tumor also. Acha. If you ask about the immunohistochemistry of the carcinoid, they will be synaptophysin, chromogranin, and neuron-specific analytes will be all positive. So every example of carcinoid will be these cell positive. If you look at the microscopy of the carcinoid, they all will show you, suppose this is a area microscope, they'll show you such type of round, they are clearly looking round tumor nests, and each of this nest will have what? They will have such type of tumor cells assay. And the tumor cell will have what? They will have the salt pepper chromatin like this. They'll have salt pepper chromatin. Okay, so they will have what? They will have tumor nests, and they'll have tumor cells, and each of the tumor cells on the EM will show you the neurosecretory granules, and each of these granules has all those hormones we talked about, that is serotonin, VIP, ACTH, and all of those will be positive in what is called as a carcinoid. Okay, that's all about the carcinoid we're going to talk about today. Acha. One more question asked to me is about the outline of the TH cells and the cytokine seen with them. So the question that is asked to me is about the T cells. In fact, T helper cells. TH cells, that is T helper cells. T helper cells. So again a question becomes, sir, what is TH cells? If you look at the name, it is T helper cell. That means this cell will help other cells, right? This cell will help other cells. So what happens is, suppose I talk about a APC, it's a antigen presenting cell, and the APC on the surface will have supposedly a molecule called as MHC. This APC is presenting a cell to the TH cell. The TH cell is taking this by a T cell receptor. Ab dekho what happens, suppose I talk about this as an antigen. So what happens, this APC, it is going here and there, it catches this antigen, it takes this antigen, and together, now this whole thing together will bring this antigen and will present it to the T cell receptor. This is how the entire presentation occurs. This will present this to the T cell receptor like this. So what is happening is, the APC is presenting an antigen to the T cell receptor, which is identifying this by the TCR. Okay. Apart from this, there are some other molecules involved, which are not talking about this right now. But yes, what happens is the APC, it actually releases some cytokines which stimulates the TCR. There are cytokines which stimulates the TH cell. Okay. Now, based on the cytokine, now this is a very important fact. Based on the cytokines, the APC presents the antigen to the TH cell. Okay. Are you getting this point? So what happens here is, dekho, if I talk about the different type of antigens, suppose there is a APC. I am talking about the three types of APC we should all know. Okay. अब क्या होता है देखो, the APC is presenting supposedly a chronic antigen, okay, a chronic antigen to a TH cell. So the first question asked to you is which type of TH cell it is. The answer is TH1 cell. Second question is the APC is presenting what? The APC is presenting the allergen or any parasite to the cell. It will present to the TH2 cells. Third question often asked is the APC is presenting a bacteria or a fungus, and that presentation occurs to TH17 cells. Now, once the TH is being activated, TH1, TH2 or TH17, the TH1 will then release interleukin 2, 12 and interferon gamma. कैसे याद रहेगा? See, very easy. The APC will release the IFN gamma to activate a TH1, and the TH1 is then releasing IL-2, 12 and IFN gamma again. The IL-2 will self-activate the TH1. Please understand, a T helper cell is called as T helper because it helps other cells. But a cell can help other cells only when it's helping itself. I can help you only if I study myself. If I don't know these things, how can I teach you, isn't it? If I don't know these things, how can I teach you? That means I help myself and so I help you, isn't it? So similarly, it is a TH1 cell, it is helping itself first and is then helping also CD8 T cells, and 12 and gamma is then helping what? It is helping a macrophage. Now remember, these TH1, CD8 and macrophage, they will all activate and will then act on what? A chronic antigen. It's as simple as that. And then comes the allergen. TH2 releasing IL-4, IL-5 and IL-13, where IL-4 will activate a B cell to release IgE, IL-5 will increase the eosinophils, and IL-13 will release the mucin. And as you understand, for allergen, what you all want is immunoglobulin E, you want eosinophil, and you surely want a huge amount of mucin to cuff this allergen out of your respiratory system. Now comes the role of TH17, releasing IL-17, IL-22, and this actually will activate the neutrophils and monocytes, and hence the three type of TH cell is helping other cells. TH cell help other cells. Now if your question is, sir, which cell a TH cell helps, please listen to me again carefully. A TH cell will help what? First of all, itself, okay, then CD8 cell and the macrophage will also help. B cell to release IgE, will help eosinophil, will help neutrophil and monocytes. Now, which are the cell being helped by a TH cell? Again, batao. From this side, a TH1 cell, CD8 cell, macrophage. TH2 cell, B cell, eosinophil. TH17 cell, neutrophil, and yes, it is the monocytes. So all of these cells are being helped by the TH cells, and therefore we call this T helper cells. T helper cells. Okay. Achha. Now a question being asked to me is, sir, please let me know about the primary biliary cirrhosis and the primary sclerosing cholangitis. PBC and PSC के बीच में difference in the histopath. The question asked to me is in histopath, but I'll talk about, देखो, the first thing you should understand is PBC and PSC full form you all know. It is primary biliary cirrhosis, okay, primary biliary cirrhosis, and this one is primary sclerosing cholangitis, okay. How will you differentiate? First, look at the involvement of the bile duct. Remember one thing, a PBC involves intrahepatic bile duct, a PSC involves intra and extrahepatic bile duct. Okay, that's the first difference. Second difference in the antibodies, the PBC is involving the anti-mitochondrial antibody, while the PSC involves atypical perinuclear ANCA. And if you look at the liver biopsy, so if you see, suppose there is a, if I draw, this is a polar triad, okay, it's a polar triad. Let's assume it's a polar triad, looking like a smiley. It's not a smiley, it's polar triad, okay. अब क्या होता है देखो, you see a huge number of lymphocytes in and around the bile duct like this. You see a huge amount of lymphocytes in and around the bile duct. It is called as PBC. It is called as florid duct lesions. It's called as florid duct lesions. And along with that, the PSC. What is PSC, beta? PSC में there is a huge amount of what? Collagen. Yes, there's collagen like this, the goal like this. It is called as onion skinning appearance. So what is the question being asked to you is, first of all, in the PBC, क्या दिखता है? It is called as florid duct lesions. Okay, it is called as florid duct lesions. And in the PSC, what is there? In the PSC, what is there? Yes, it is a collagen deposition, and hence we call this onion skinning appearance. Onion skinning appearance. Okay, I hope it is very clear about the differentiation of PBC and the PSC. Okay, one more question that can be asked here is, sir, which disease is often seen with a PSC? Because of the atypical Priyanka, it is often seen with ulcerative colitis, because ulcerative colitis also has the same antibody as a PSC, okay. Chalo. So that is one thing that I actually explained to you. Are you still with me or left out? How many of you are there? Raise hand. Raise hand. Yes, I am there. Present, sir. Present, sir. How many of you are there? Present, sir. Present है कि नहीं? बताओ. Present or not? Present or not? अब not हो गया तो obviously you will not be able to say present. But I want you all of to say yes, sir. Present, present, present. Every one of you. Next question. Chalo. Okay, these questions like GT score increasing, I'll take a separate session on this. This is completely academic session in which I want to clear your doubts only. Okay, this I'll take a purely academic session. Let's talk about that only. I want to cover that. हाँ. अच्छा, motivation भी चाहिए तो फिर एक like देना पड़ेगा वीडियो को. Put a like on the video and then put a motivation session also. कितने लोग present हैं? I got present कितना मिला? हाँ, okay, good. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. अच्छा, okay, चलो, ठीक है. So I think lot of you are there then. चलो. Oh, मेरा laptop हो गया off, but कोई बात नहीं, we have to put it on. चलो, let's put this on. I have been recording this since morning today. Okay, I am in this studio today. I took a leave from my hospital, and I'm from 9 a.m. I am in this same studio from 9 a.m. I am here only. So live with the laptop has to get on. It will take some time, but I am still there with you, and let's start the session again. हाँ, चलो, I'll take in the question. Number 1 question. हाँ, चलो आ गया. My laptop is switched off. Okay, so I'll take the next question from you. The next question being asked to me is, yes, it's 9 p.m. now, and I have been here since 9 a.m. That is how we work hard. We work hard for you, and you work hard for yourself, and ultimately that gives us both a result. Okay, if you are there with me till the end of the today's session, I'll surely motivate you. But let's first try to solve your doubts here. A question asked to me is, sir, can you explain dimorphic anemia? Okay, what is a dimorphic anemia? Very good question. Dimorphic anemia. देखो, suppose, I'm taking an example. Suppose a patient has iron deficiency anemia, so he will show you microcytic hypochromic RBCs. Okay, that's very sure. Now, suppose a patient has a B12 deficiency anemia, तो क्या होगा? He will have macrocytic RBCs. You agree? Now, if you see both of them are together, they are together in a patient, in that case, you will see some microcytic RBCs and some macrocytic RBCs. And therefore, it will be called as a dimorphic anemia. So, dimorphic anemia is a condition where you see both types of anemia, some microcytic also and some macrocytic anemia also. That type of anemia is called as a dimorphic anemia. A second reason of dimorphic anemia is, suppose a patient has iron deficiency anemia and then you give him treatment. You give him iron therapy. So because you give him iron therapy, so what happens? There is some microcytic and some cell which is completely normal. And because of this normal type of RBCs, it becomes what is called as iron deficiency anemia. Okay, iron deficiency anemia. Okay. Okay. अच्छा, Uh, One more question asked to me is, I'll just take this question from Ish Bandhu. Sir, can you please explain P53 carcinogenesis and MDM2? हाँ जी सुनो देखो, what is the action of P53 gene? Let's first understand the P53 gene concept. The P53 gene concept says that actually this gene is what? It is a molecular, it's a molecular policeman of a cell cycle. It's a molecular policeman, also called as guardian of genome. It's a guardian of genome. अब देखो, let's talk about this guardian. How does a guardian function? How have your guardian taught you to be in the line of getting into so much academics, because they have taken care of every problem that you had and they have sorted it out. They have been knowledgeable about your wrongdoings and they have thrashed you, they have scolded you whenever you have taken a wrong path, isn't it? Similarly, the P53 also is a governor of our cell cycle. Whenever our cell goes in a wrong path, suppose there is any sort of hypoxia-induced cell injury, hypoxia-induced cell injury, or there is any sort of oncogenic or oncogene activation. Oncogenic stress means simple means oncogene activation. So both of them will activate P53. The difference is the hypoxia-induced cell injury, they will activate a gene called as ATM and the ATR, which activates P53, and the oncogene can also activate P53. अब देखो, the P53 has got activated. Because it has got activated, the P53 will then activate what? They'll activate P21. अब देखो P21 क्या है? क्या है ये P21? P21 is a protein that is actually a cell cycle inhibitor. It belongs to the CYP family, isn't it? P21, P27 and P57. This P21, it actually puts a brake on a cell cycle because it puts a brake on G1S more than G2M of a cell cycle. The moment a cell cycle stops here, it activates what is called as a repair mechanism. If the repair is possible, it will go back to cell cycle, and if the repair is not possible, it will cause either apoptosis or a break on the cell cycle called as senescence. Simple mechanism action. It is something like, because of any wrongdoing of the cell, they have activated P53. P53 activates P21. P21 is the, ये father है तो ये mother है. Father will tell the mother, बच्चा कर रहा है गड़बड़, उसको stop करो. Mother बोलेगी बाहर जाना बंद. It will activate, it will stop the G1S and G2M, will start the repair activity. If repair is okay, go out. If not okay, घर में रहो, or will not and never go out. Apoptosis or a senescence. Sir, you asked me what is MDM2. The P53, it activates what is called as MDM2. The MDM2 is like an inhibitor. Okay? MDM2 is an inhibitor of P53. So P53 activates MDM2 so that whenever the action of P53 is more, or is it a need to activate more? If there is no need of the P53, this MDM2 will inhibit P53 and therefore the action of P53 will be controlled. So if there is no MDM2, the P53 will function more. Okay? If there is no MDM2, the P53 will function more. Okay? In opposite language, if there is MDM2 is more, it is more, then it will inhibit P53. So if this is increased, this one is decreased. And hence, one type of carcinogenesis is increase of the activity of MDM2. Okay, MDM2 can also cause carcinogenesis in the same manner. I think, is it clear? If it is clear, everyone give me a thumbs up. Yes sir, samjh mein aaya. Give me a thumbs up if you have understood this. Okay. Sir, can you tell me the basic rules to identify the different types of immunodeficiency disorders? Arey Baba Anjana, you have asked me a full 1 hour chapter topic. Okay, I'll take this. Please remind me again. Sir, why in GVHD the self T cell receptors responses to non-self APC MHC molecules? Because the antigen are foreign. That is why it happens. SLE, okay. Can you explain those RCC? क्या बोल रहा बच्चे? Can you explain those RCC? कहाँ गया question? RCC syndromes like Vagar. Okay, there are three types of syndromes with Wilms tumor. You should remember those. Number one is WAGR, Vagar. Okay, Vagar is Wilms, aniridia. Okay, gonadal malformation and mental retardation. ये क्या है? Vagar है. Okay, first. Second is Dennis Drash syndrome. Dennis Drash syndrome is when there is a Wilms tumor. And along with Wilms tumor क्या होता है? There is a gonadal dysgenesis. Okay, there's gonadal dysgenesis. There's also mesangial cell dystrophy. Okay, the third one is what? It is called as Beckwith-Wiedemann syndrome. Now, how I used to remember this is, if a patient has Wilms tumor and everything is wide, bigger, like macroglossia and hemihypertrophy. Okay, macroglossia and hemihypertrophy, everything is wide. It becomes again a finding of the Wilms tumor. Okay. Avinash, how are you, sir? Please explain me yesterday's question on GIST. Okay, I'll take this question on GIST. There's one more question. What the following is not true? SDS deficient GIST. Acha, negative for c-kit. Acha, देखो, very good question. देखो, what happens is, if we talk about this GIST, तो GIST basically has a mutation of which GIST का mutation क्या होता है? GIST mutation is mainly the CD117, which is nothing but a c-kit mutation. Okay, c-kit mutation is the most common one. They often also have PDGFR alpha mutation. But in those cases which do not have this, if the above two are absent, in that case they have a SDH, that is succinate dehydrogenase loss. And this case is often seen in a case of pediatric GIST. Okay, they're often seen in pediatric GIST. This is often referred to as Carne-Stratakis syndrome. It is often referred to as a Carne-Stratakis syndrome. Okay, Carne-Stratakis syndrome. This GIST also has a site in the stomach, so that is a right answer. But remember, they do not show Carne's triad. Carne's triad is seen in the usual GIST. This will show what is called as Carne's triad. Now, why is this mutation important? Because if a patient has a mutation of GIST and they show the c-kit, it is often treated with tyrosine kinase inhibitor, which is imatinib. So therefore, we always look for mutation, because we also have to add chemotherapy along with the resection in the GIST cases. Sir, please explain viral hepatitis serology. Okay. So soft tissue sarcoma पढ़ना चाहिए? देखो, पढ़ना चाहिए मैं कैसे बोल दूं नहीं पढ़ना चाहिए? तो पढ़ना तो चाहिए, बट अगर आप पूछो सर क्या पढ़ना चाहिए, in that case I'll suggest you read at least rhabdomyosarcoma. That is one tumor you must read, rhabdomyosarcoma, and the mutations involving the liposarcoma. बस, that is more than sufficient for you. अच्छा, sir, please explain biphenotypic leukemia, Disjaminoma. There's two things it is also asked to explain. Let's talk about this. Talking about the biphenotypic leukemia. देखो, let's assume I'm putting in a form of a flow marker. Okay, in a flow marker. Now I'm giving you some flow markers and I'm putting these as a cutoff lines here and here. Okay, now here is written MPO. Okay, is written CD34, or let me write this right here, MPO, and here it is written as CD19. Okay, and in this case I'm putting few other markers. It is suppose MPO and CD34. Okay, now suppose the color shown with a cell here in this case is a cell having MPO positivity, okay, and some cell are 19 positive, okay. And now these cell in the other case, they also are showing you MPO and C34 positivity like this, okay. And if I talk about this case as a one more, suppose I take this one, just put this as a small one, let's make this a smaller one, assay, okay. And I'm putting one more example for you. Suppose I take this as a marker, this as a marker, so this as a scatter plot, and I'm putting two type of marking here. One is supposedly again 34, and here it is CD19. Now what has happened is 19 cell is showing you here again. So what has happened is this cell is 19 positive and also MPO positive, but the same cell here is 19 positive and 34 positive. That means this cell is showing you 34 also, 19 also, and MPO also. 34 also, 19 also, and the MPO also. And hence, what happens is, if you see a case of biphenotypic leukemia, okay, so what happens if there is a single population of cells having a specific marker, like they have CD34 also, they have 19 also, example mein, and the same cell has CD-MPO also. This will be called as a biphenotypic leukemia, okay, biphenotypic leukemia. But if there is more than two population of cells, one of them having 34, one of them having CD34 positive and 19 positive, and other of them having 34 positive and MPO positive. So this is one type of cell, and this is one more type of cell. This becomes what is called as a mixed phenotypic acute leukemia, okay. So biphenotypic mein a same cell has 19 also and MPO also, whereas in mixed phenotypic, different cells have the two marker positive, but these two type of cells are in the same patient, and hence being called as mixed phenotypic acute leukemia. Acha. Next question asked is, sir, Disjaminoma. Okay, good question. Disjaminoma. First of all, you should understand that what is a Disjaminoma? Disjaminoma. देखो, Disjaminoma is the female counterpart of seminoma. Okay, it's a female counterpart seminoma because Disjaminoma occurs in ovary, whereas seminoma occurs in testis. ठीक है? Both of them have the same tumor marker, and what is the tumor marker for both of them? It is placental alkaline phosphatase and the lactate dehydrogenase ठीक है? अच्छा, अब देखो, Disjaminoma and seminoma, they both have some mutations, and this is very, very important. They often have a mutation of, they have the same type of mutation which is actually belonging to, you'll say it is actually a type of a pluripotent gene. It's a pluripotent gene, and they can belong to the category okay. So they actually belong to the pluripotent gene. They belong to again the c-KIT mutations. They often belong to the c-KIT mutations, and that becomes a very, very important part in deciphering whether it is a Disjaminoma or seminoma, because both of them will have the same thing, that is a c-KIT mutation. Okay, they will both have the same mutation, what is called as a c-KIT mutation. Now often they have some other mutations which you can remember if it is possible for you, that Disjaminoma, apart from this, they often have some other mutation, but all of them actually are what? They are pluripotent gene only. They all are pluripotent gene only. Acha. Now see, both of them, they have, suppose there's a microscopic feature here, they all will have these type of collagen running here and there, okay, and this collagen will make some sort of, the septa, and inside the septa you'll see the large or medium to large cell tumor cells like this, and each of them will have a nuclei, and the nuclei will have a nuclei like this, okay, like this. If you just enlarge it, this cell nucleus with a clear cytoplasm, and they'll have one or two nuclei. This is a clear cytoplasm. It's a clear cytoplasm. The entire of this tumor looks like this, and in this area of fibroblast, there's lymphocytes here. There are lymphocytes here, ऐसे. Okay, this is how the Disjaminoma and Seminoma, both of them are there. Okay. Daily quiz are important. It's helpful. Thank you, and ensure that you also appear for the daily quizzes. Okay. Sir, इज देयर एनी डिफरेंस ऑफ नोट्स कॉन्सेप्ट जो आप 17, 18, 19 और आजकल पढ़ाते हैं? देखो चंद्र प्रकाश, इज अ वेरी गुड क्वेश्चन. यूजुअली व्हाट हैज हैपेंड ओवर द ईयर इज दैट द पैटर्न ऑफ क्वेश्चंस हैव चेंज्ड फ्रॉम अ सिंगल topic questions to a subject question. In fact, integration subject becomes very important. So nowadays what I'm doing is I'm just trying to integrate your pathology to your topic of medicine, pediatrics, gynae, obs and surgery. So that integration becomes more important, and that is what makes me different from the rest. Okay. अच्छा, क्या क्वेश्चन पूछ रहे हो सर? ग्लासमैन थ्रोम्बोसिनिया में कोगुलेशन विद एडीपी फिब्रिनोजन इज एबनॉर्मल, अंडरस्टूड, बट व्हाई एबनॉर्मल विद रेस्ट्रोसिटिन? ओके, देखो क्या होता है, सपोज आई टॉक अबाउट दिस एज अ ब्लड वेसल. ये मान लो वेसल है ना, दिस अ ब्लड वेसल. ओके, एंड दिस इज द एंडोथेलियम. ओके, now if I talk about this injury, suppose there is an injury here, so from the injured part what expresses is a von Willebrand factor, right, VWF. अब this is a platelet, right, and platelet adheres to this by GP1B9. Platelet adheres to this by GP1B9. Let's mark it. देखो, this is what VWF and this is what GP1B9. ठीक है, ये क्लियर है? अच्छा, ये प्लेटेट है. Now if I bring one more platelet here and if I tell you they both are aggregating, so this both will aggregate by GP2B3A. ये क्या है? They are GP2B3A. Okay, and between them comes what? What is here? It is a, now this is very important. For those getting confused, listen, this is either a VWF or it's a fibrinogen. Okay, now when you are adding ADP, or if you're doing some test called as a platelet agglutination test. Okay, now suppose in this test you are adding ADP, you're adding serotonin. Now these two are what? Agonists of platelet. So what they do is they actually increase the aggregation. So if there is no aggregation with these two, definitely something is wrong here. This is wrong, right? So if there's any abnormality in this case as not aggregating, 2B or 3A is abnormal, and hence we call it is a Glasgow thrombocythemia case. Now your question is, sir, why it happens in retrocytin? That's what your question is, right? So your question on retrocytin is, so if you add resto will activate VWF, agreed? Okay, and VWF, it not only causes addition but is also involved in, देख रहे हो, aggregation, understood? Because you're adding restocytin, it should help also in aggregation. If this molecule is not there, then what will happen? Again, there is an absence of restocytin. Or if this is not there, again the same problem. What's the point? If there is no WF, no aggregation. Similarly, if there is no GP2B3A, again no aggregation. Got the point? And therefore the GP2B3A shows decreased aggregation with ADP, serotonin, and also, yes, also restocytin, because resto activates this one. Resto activates VWF. Is it clear? अगर हाँ तो बोलो हाँ जी सर, चलबे, बुझते पारलम? चलो, ओके. नेक्स्ट क्वेश्चन, सर DIC, ओरी बाबा, DIC. अच्छा देखो, सो व्हाट इज DIC बेटा? देखो, DIC is nothing but disseminated intravascular coagulation. बेटा देखो, last 8 minutes I will not be able to take any doubts here further. I'll just take this as a last doubt, and finally I'll talk about your preparation only. Okay, this is the last doubt I'm taking here. DIC stands for disseminated intravascular coagulation. So what happens here? Suppose a patient has any sort of tissue injury, okay, tissue injury, or the patient has any sort of vascular injury. Okay, now these two will release what? Tissue factor, right? A tissue factor should activate the coagulation pathway. This should activate the coagulation pathway. Okay, that's what it does. It actually activates the coagulation pathway. But what happens is, See, this is a very severe injury, and this is a very severe vascular injury. So the moment they activate the coagulation pathway, at the same time, suppose there is a, I'm just drawing this in this form. Suppose there's a blood vessel here, ये vessel है. So in the vessel, the platelets are coming together, okay, and making a clot. Okay, this makes a clot. Now, because it makes a clot, two things happen. Number one, the RBCs which are passing from here, when they come in contact with the clot, they break like this. And what comes out is a RBC looking like this, and hence called as a helmet cell. It is what is called as microangiopathic hemolytic anemia. The second problem it causes is because they consume all the coagulation pathways. Okay, they consume. Okay, because they consume the platelets plus the coagulation factors. What they do is they decrease these factors, and because they decrease the factors, it what is called as consumptive coagulopathy, and ultimately the patient ends up in bleeding. This huge amount of clotting is causing the ischemia to multiple organs. So because ischemia to multiple organ occurs, it causes what is called as multi-organ failure. And here, because it is also activating this coagulation pathway, they will also activate fibrinolysis. So clot, as is breaking, will also break down. So when they break down, what will happen? This will lead to FDP and D dimer level increased. So these two are increasing because the clot is also breaking down. Therefore, what we'll see in the lab finding is, in the lab test, there's increase in the PT, increase in the APTT, decrease in the platelet count, and apart from this, what you see is there is FDP and there is D dimer, because these two indicate what? These two indicate the clot breakdown. And why is the clot breaking down? Because the clot will always break down, because our body will always activate fibrinolysis. As soon as it activates clotting, will also break it down. So when a clot makes a clot and breaks the clot, when the clot breaks, it forms FDP and the D dimer levels. Okay? FDP and the D dimer levels. Acha. So I think that is the end of what I'm taking today. And before I move to the end of today's session, please listen to me carefully. Whenever you read pathology, always try to correlate this to what is happening to a patient. Suppose we don't read about DIC, just don't stop here. Think, when a patient comes with DIC, what will happen? He will surely have bleeding. He will always have multiple organ failure, and he will have hemolytic anemia, so he will always have jaundice also. Because of this, the patient will initially have the tendency to clot, but ultimately he will end with bleeding. So how will this patient present with? You should relate pathology always with clinical sciences. Suppose there is a patient in MICU or a surgical ICU, and your nurse comes to you complaining that when she's putting a cannula, the patient is bleeding, and bleeding is not stopping. You got a lab investigation done, the platelet count came to be low, the PT and APT was high. What is the next test to be done? You are thinking about DIC? If yes, do a FDP and dimer level. If it is high, you're confirming it's a case of DIC, and hence you give what? That is what you must read. Don't stop here. You must give a patient a fresh frozen plasma, because as soon as you give him FFP, it will replenish all the coagulation factors. And that is when the patient starts getting cured. And more importantly, you learn these things only with more and more skill development happens in your ward postings. Ensure you do the ward postings, and if you are not able to do it, koi baat nahi, listen to us carefully. What we speak is more important than what we do. So when we speak, listen to us carefully. That is what you can do from your end. Often also, it is very important to understand that whenever you are reading pathology, try to correlate stuffs with what you have read in the clinical sciences. For example, let's talk about nephrotic syndrome. Just don't stop after reading the types of deposition, the levels of complement. Always try to read the treatment part of the nephrotic syndrome. That is, you give steroids, cyclophosphamide, mycophenolate meflotil, or immunosuppressants. And then when it's not treated, when you need to do dialysis. when is dialysis required in RPGN? In RPGN, treatment becomes anti-hypertensive drugs. Why? Because it will lead to acute renal failure within 4 weeks. So what test you should do there? So all of those things will be correlated only when you have an in-depth knowledge. It's very simple to understand because in-depth knowledge is not gained in one lecture. When you listen to a lecture, try also to read the same thing in the textbook. But if you're an intern, I understand it's not very possible for you. So at that point of time, if you're not read it very carefully, or you can try to correlate the same thing in the medicine teaching or in the surgical teachings. But always try to correlate to what is happening in a patient. Just don't isolate to the pathology only. For example, if you talk about the gist. Of the gist we all have understood today, it was showing you CD117, c-KIT and the PDGF alpha. Now, if there is no c-KIT, I told you we must look for SS mutation. But then you should understand, is gist resectable tumor? Then you should understand, is this benign or malignant? It's a type of benign tumor. So is it resectable? Yes, it's resectable. But what other drug can you give? You can give imatinib. So try to read these stuffs also from your surgical textbooks. Only then you consider your topic to be complete. Else, do not stop in pathology. Okay? Once you start making this as a regular habit, it will really make your life easier. I will never be tough for you. Okay? Okay, there's one more thing I'll just talk about this. Sir, most common morphological difference between Crohn's disease and ulcerative colitis. So options are diffuse. Okay, you just retract this message, but I got this also question in your, I'll take this question because it was also asked to me in the email. I'm very sorry for missing this. Diffuse distribution of pseudopolyp is the right answer. Mucosal edema can happen in both. Crypt abscess can occur in both, and lymphoid aggregate can surely occur in both. Right answer here is diffuse distribution of pseudopolyp is seen in a feature of ulcerative colitis, and it's not seen in Crohn's disease. Okay. So, thank you all of you for joining me today. I wish you all the best. Do let me know in your comments below as to whether this session was useful for you or not. It will help us to motivate ourselves more, and maybe we can come more frequently to solve your queries here itself. Okay, thank you guys for giving your valuable time and your valuable inputs throughout my lecture. Wishing you all the best. Take care, enjoy, and stay happy. Bye-bye.